Hello and welcome to Grand Rounds for the Minnesota Regional Spinal Cord Injury Model Systems. We call it MINSCIMS for short. Thank you so much for joining us today. So MINSCIMS is funded by National Institute on Disability, Independent Living, and Rehabilitation Research. It's called NIDLR for short. And their purpose is to support innovative projects and research in the delivery, demonstration, and evaluation of medical, rehab, vocational, and other services to meet the individual's needs with spinal cord injury. Next slide, please. MINSCIMS represents an exciting partnership among the following Minnesota institutions. We have Courage Kenny Rehab Institute in Minneapolis, the Mayo Clinic in Rochester, Regions Hospital in St. Paul, and the University of Minnesota in Minneapolis. Next slide. Our community collaborators include Minnesota Spinal Cord Injury Association, Unite to Fight Paralysis, Get Up, Stand Up to Cure Paralysis, Paralyzed Veterans of America, United Spinal Association, and the North American Spinal Cord Injury Consortium. This system collectively provides a multidisciplinary continuum of care for people with spinal cord injury, including emergency medical, acute care, acute rehab, and post-acute services. I'm Angie Philippus, and I will be the moderator of today's session. I'm a research project specialist in the Department of Rehab Medicine at the University of Minnesota Medical School, and I'm part of the MINSCIMS. Next slide, please. A couple of housekeeping things. The University of Minnesota has organized the CME for today's webinar. So see the chat for information on how to record your attendance and claim CME credit for attending this webinar within 24 hours of the event. This meeting is being recorded and will be posted on our MINSCIMS website. But due to the number of registrants for today's webinar, we've placed phone lines on mute to reduce audio feedback. However, we welcome and encourage audience participation using the Q&A function. And if you have any kind of technical or logistical questions, please submit those via chat to Dan Kelly. We extend a huge thanks to those who work behind the scenes to make these webinars possible. Next slide, please. The title of today's presentation is Weighing the Risks and Benefits of Psychedelic Therapy for Spinal Cord Injury. And we are excited to welcome the speaker for today's webinar, who is Dr. Jessica Nielson. So Dr. Nielson is an assistant professor in the Department of Psychiatry and Behavioral Sciences and core faculty in the Institute for Health Informatics at the University of Minnesota. And Jessica completed doctoral training in the lab of Dr. Oswald Stewart at UC Irvine, focusing on animal models of spinal cord injury. And she did postdoctoral training with Dr. Adam Ferguson at UCSF, where she developed a preclinical database of spinal cord injury studies that seeded the open data commons for spinal cord injury. She is currently principal investigator of several studies, including an R01 from NIMH, focusing on machine learning to better understand PTSD, depression, and problematic substance use. Also, the first psilocybin clinical trial at the University of Minnesota to understand how psilocybin induces neuroplasticity in the human brain, and conducting several anonymous online survey studies about the unique perspectives of marginalized groups that are often excluded or not represented in psychedelic clinical trials, as well as research into how people with PTSD respond to ayahuasca. She is also a sub-investigator for a phase 3 clinical trial with psilocybin for treatment-resistant depression, and that's set to start enrolling in the next few months. Outside of academia, Jessica is a grassroots community organizer aiming to promote education and harm reduction around psychedelics. She is the founder and executive director of the Psychedelic Society of Minnesota, which is a 501c3 nonprofit. Also, the Innovation Alchemist at Big Psych, co-founder of the Decrim Coalition that recently advised Mayor Fry on the executive order to deprioritize entheogenic plants and fungi in Minneapolis. And she was recently appointed by Governor Walz to serve on the Psychedelic Medicine Task Force. Welcome, and thank you so much for presenting.
Yeah, thank you so much for having me. So these are just some of my disclosures. Okay, And just a quick disclaimer, the information presented here is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment recommendations. All content, including text, graphics, images, and information contained on or available through this talk is for educational purposes only. And if you want to see current clinical trials with psychedelics, you can go to clinicaltrials.gov and search for those. And also, I am a neuroscientist and not a clinician or medical doctor. So some of the learning objectives for today, first is to know the history of psychedelics, and then to understand objective and subjective effects of psychedelics, identify common psychedelics and know the therapeutic and healing uses of some of these common psychedelics. And then unique to this audience is being aware of the unique risk factors that are coming to light regarding people with spinal cord injury that have been using psychedelics. So a brief overview of what I'm going to talk about today. First, I'm just kind of going to give an overview of what psychedelics are. You're going to kind of hear this term entheogens and psychedelics used interchangeably. So I'll go into what that means. Next, I'll talk about the history of psychedelic research, some of the mechanisms for how we think psychedelics are changing the brain, and some of the unique reactions in people with spinal cord injury that try psychedelics. So what is this term entheogen? So entheogens are psychoactive substances that induce alterations in perception, mood, consciousness, cognition, or behavior for the purposes of engendering spiritual development or otherwise in sacred contexts. And this really refers to their indigenous uses. And so a lot of these substances have been used for thousands of years by indigenous cultures safely and effectively for different kind of spiritual, cultural contexts. And, you know, a lot of those practices predate our modern drug laws that have actually made them illegal. So some of the common entheogens that we think about, and these are usually like plant or fungi-derived psychoactive substances, including psilocybin-containing mushrooms, ayahuasca, ibogaine, and mescaline-containing cacti, just to name a few. So entheogenic plants and fungi are central to ritualistic and traditional medical practice in indigenous cultures worldwide, and civilizations have used them for thousands of years. And in sort of this resurgence of the quote unquote psychedelic renaissance, a lot of this kind of ancient indigenous use is often minimized and not really acknowledged in terms of the long history of safe and spiritual use. And so I just want to kind of give a shout out to that and make sure that we're staying aware of a lot of the harms that have actually been done throughout the past century or so, really trying to extract some of these medicines for use in kind of the Western medical model, and just kind of want to make people aware, you know, that these aren't new. They're very, very old, and they've been used for a very long time. And I think we need to approach these things with reverence and respect, and also paying homage to the indigenous cultures that really kind of hold the knowledge around the appropriate use of these things, specifically in kind of spiritual and healing contexts. So in terms of the quote unquote modern history, given that these have been around for thousands of years, some of the more early scientific research that we think about in kind of the westernized world. In 1896, mescaline was first isolated from peyote. In 1938, LSD, or sometimes called acid, was synthesized at Sandoz Research Labs in Switzerland by Dr. Albert Hofmann. He initially marketed as dilyside, and it was thought that it could be a tool to aid the release of repressed material during therapy. And it was widely disseminated to psychiatrists at the time to help them sort of understand the experience of the world of their patients. There were some experiments done with LSD in the 50s that people were trying to think of how they might be helping to understand psychosis in schizophrenic patients. And so it got coined with this term as being a psychotomimetic, which means a drug that mimics psychosis. And I'll get into why that's actually not true. The government also got a hold of it during this time. There's this famous MK Ultra experiment that was conducted by the CIA, which they thought could be used as a truth serum for interrogations, which went horribly wrong, and a lot of harm was caused, and a lot of misconceptions about what LSD does kind of perpetuated that at the time, which was really unfortunate. In 1959, Albert Hofmann, the same guy that first synthesized LSD, received some mushrooms that he received from Oaxaca, Mexico, and was able to extract psilocybin from it. And initially, he called it endocybin when he first extracted it. So around that time, there was a lot of people doing various drugs of quote unquote abuse. And so, there was the hippie counterculture movement in the 1960s. There was also the civil rights movement. And so there was a lot of people in the public doing cannabis and psychedelics and LSD and magic mushrooms and mescaline. And they were actively protesting the war and the civil rights and things like that. And the government recognized that they couldn't crack down on these communities for exercising their First Amendment rights. And so they actually found a loophole, which has since been admitted by someone from the Nixon administration who was in office at the time, admitting that they actually created the Controlled Substances Act to be able to crack down on these communities so that they could arrest them and put them in jail. And it was really unfortunate because the backlash of that has been very, very harmful over the last 50 years or so. And it's been a massive failure. There's been a lot of propaganda that hasn't really been evidence-based around the harms of different controlled substances like marijuana, LSD, psilocybin, things like that. Just perpetuated a lot of kind of secondary complications with violence and the underground black market around drugs, while at the same time, the FDA has been pushing a lot of these other drugs that claim to have some benefits. So it's more of like a war of drugs where some drugs are considered medicine and they have a lot of side effects, whereas these other drugs that have been used safely for thousands of years are considered the most harmful drugs in existence, being in Schedule 1. It's just really been a really horrible process that has kind of indoctrinated a lot of people in our generation and generation above, kind of like older people, to thinking that psychedelics are extremely harmful. They put holes in your brain, they make you crazy, things like that. And none of that is true. And it's all just been propaganda to really push the war on drugs and the war on people who use drugs. And so this, was really unfortunate because there was actually a lot of really promising research happening in the 50s and 60s using things like LSD and mescaline and psilocybin. And so this is just a graph kind of looking at what has been published in PubMed with these various substances. Marijuana and ketamine are researched a lot. There's been a lot of effort to try to demonize marijuana, and the results are kind of all over the place. Ketamine, it's a surgical anesthetic that popped up around 1970. So there's a ton of research on it in that context. It was also recently approved by the FDA for depression. And then some of these other psychedelics that we'll get into in a minute, but you can see kind of, over time, there was kind of this uptick of research, and then the Controlled Substances Act happened and it basically shut down research. And so you see kind of this dip. And then around the turn of the century, we see kind of this rise in more research and just kind of breaking it down to the different individual substances. You can see that, while a lot of things have kind of dipped down and haven't been kind of restored to their full glory and interest that they had back in the 50s and 60s, things are kind of ticking back up as interest into them and understanding more about how they might help with mental health conditions gains momentum. And so a lot more attention is being paid to them in the scientific arena. So I want to touch briefly again on this notion of psychedelics being a psychotomimetic. So this article was really trying to review the literature on both neuroimaging studies that looked at people with schizophrenia that had hallucinations, as well as people taking serotonergic psychedelics like LSD and psilocybin to really see, is there anything in the brain that would suggest that these are in fact mimicking psychosis? And I'm not going to go into the details of all this, but basically the only thing that was found to be similar was the meaning associated with the experience or the quote unquote hallucinations that.
Oh, Jessica, I think maybe we've lost you. Shoot. I know Jessica was having some technical difficulties a little bit earlier when she was first joining, so hopefully we can get her audio back on track here soon.
I'm sorry, did that stop for a while?
It did, yeah. But you're back now.
What was the last thing you saw?
So go back. Back more. Yep, more.
Discussing the meaning.
Yep, the meaning.
Yeah, okay. Sorry about that. I'm at a hotel and the internet is not great. Okay, so the only thing that's really similar with psychedelics and psychosis is the meaning associated with the kind of altered state of consciousness that they have. And work from my lab, from a PhD student that graduated last year, actually showed using some EEG techniques and psychophysics behavioral tasks that there's actually the opposite effect when people are trying to do this visual discrimination task and perceptual task, and people are really able to determine context much better in the kind of context of having altered states of consciousness, whether they're having visual hallucinations or a psychedelic experience on psilocybin. So just further evidence that psychedelics like psilocybin are not psychotomimetic. Okay, so in terms of kind of integrating this into our modern culture, as I was alluding to, they were popularized in Western cultures in the 1950s and 60s, but then became Schedule I substances in the 1970s. But there has been a recent revival in psychedelic research with MDMA for PTSD, and psilocybin for depression being granted breakthrough therapy status by the FDA, which just means they're really trying to make sure that these things can get pushed through because of how promising the preliminary evidence is from the phase 2 and phase 3 clinical trials that have been generating knowledge about how these things might be effective for these conditions. So in terms of some of the objective effects, so these are things that we can actually measure with instruments when people are on psychedelics. So one of them is kind of what's going on in the brain. And there's kind of this buzzword going around about the default mode network, and it is impacted by psychedelics. There are a lot of things in the brain that are impacted by psychedelics, but this is the one that's kind of been getting a lot of attention recently because it's one of the networks involved in kind of rumination and things like that. So it's hyperactive when people are depressed or having other kind of like psychiatric issues. And so a compound that can actually modulate this network really effectively, like psilocybin, is really interesting from a therapeutic perspective. And so what this study found was these are basically fMRI networks. So the way that the brain regions are connected to other brain regions in terms of functional connectivity. So they're like active or not active at the same time. And so people were given either a placebo or psilocybin and put into an MRI machine as the drug was coming on. And we see that there is quite a lot more kind of between network connectivity happening while people are on psilocybin. And these are brain regions that maybe normally wouldn't talk to each other, whereas within network connectivity, such as in the default mode network, was decreased. Some other objective effects that are commonly seen are mostly physiological. So very, very reliably, we see increases in heart rate and blood pressure when people are on these psychedelics, as well as increases in body temperature. But some of the other things that are a little bit more difficult to really describe consistently are these subjective effects, because by definition, they're kind of unique to the person's own perception and what they're experiencing in their mind, which can be really hard to describe to another person using, linear language versus kind of nonlinear. Kind of art usually is really, really good at kind of defining what people are going through. This graphic, I don't know if this is coming through, is kind of representative of kind of these visual distortions that people might have. They might see things like this with their eyes open or closed. They might have distortions of body image or synesthesia, where music might influence more visual experiences, dreamlike ideation and processing, hypersensitivity to sensory stimuli, unusual thought processes, and childlike sense of wonder and imagination. And so there was kind of like no real research happening, after the Controlled Substances Act was initiated. And things were kind of just trickling out in the literature. There was a few people doing animal work, but it was really very minimal, not a whole lot of work done in humans. And this researcher, Roland Griffiths, who's at Johns Hopkins, he was a pretty successful, really well-respected neuropsychopharmacologist at Johns Hopkins. And he was kind of a spiritual person, had a Buddhist practice, I believe, or meditation practice. And he was interested in studying kind of mystical experiences later on in his career. And he happened to be working with someone named Bill Richards, who was kind of one of the researchers and therapists back in the 60s that was doing psychedelic therapy with LSD. And he suggested, why don't you try psilocybin? It's really great at kind of reliably inducing these quote unquote mystical experiences. And what they found in people that had never tried a psychedelic, but were somewhat spiritually oriented, was that a single high dose of psilocybin was able to produce profound effects of internal unity, transcendence of space and time, deeply felt positive mood. and ranking these experiences as one of the top 5 or the most personally meaningful experiences of their entire life. And after a single experience, that feeling persisted even up to 14 months after that one experience. So that was a pretty eye-opening finding that really kind of kicked off this kind of modern surge of interest in psychedelics like psilocybin. So the way that psychedelic assisted therapy is typically implemented is there's usually a dyad of 2 sitters, usually therapists or people that are very experienced themselves in psychedelics and really know a lot about how to help kind of hold space for people in these altered states of consciousness. And the whole idea is really to let the person kind of focus on their inward experience by reducing the amount of kind of external stimuli, by putting eye shades on and headphones with usually instrumental music, because words can be really suggestive and might kind of guide someone in a weird direction. So it's really trying to make sure that people can have this very cathartic inward experience to sort of unlock their inner healer, and that we all kind of have this inner healing intelligence, and ultimately we all know what we need to feel better. And really just creating the container in a safe space for that. And it's really important that there's a lot of preparation before these, because there can be harm done if people don't really know what to expect, and a lot of fear and anxiety. And sometimes people can be traumatized by the experience themselves, if not in the right container or not with the right people holding the space in a way that is helpful for them. And a lot of times the facilitators will kind of take what's called a beginner's mind and really not trying to guide anyone, but really just sitting there and helping them process whatever comes up and reflecting their own words back to them, and not trying to push them in any one direction, and let the participant or the patient really be the driver of that experience. So I'm not going to go into all of the literature about the evidence that's building for psychedelic therapy. Suffice it to say, it's quite a lot, and almost all of it is kind of in this mental health space. And so this is just a diagram I put together that's trying to summarize this massive amount of literature that's emerging about psychedelics for mental health disorders. And so this is just kind of looking at some of the different conditions that have literature suggesting that there might be some therapeutic potential of psychedelics for these different conditions. I show kind of these overlap because a lot of these symptoms do kind of share, like a lot of these are comorbidities that will often come together. I have a hypothesis that a lot of these things are precipitated by, early, adverse childhood events or childhood trauma or other types of trauma that then kind of seed and precipitate and are at the core of a lot of these things. And I think that's why we see these things so intertangled and mixed. And some of the work I'm doing on some of my other projects are kind of showing that this is the case. But suffice it to say, there is a lot of evidence building. There are other neurological conditions that psychedelics might help with, like cluster headaches. I'll get into that in a minute. But the main thing that most of the people in the field are focusing on right now are MDMA for treatment-resistant depression, MDMA for treatment-resistant PTSD, and psilocybin for treatment-resistant depression and major depressive disorder. MDMA has passed through 2 phase 3 clinical trials, so it is on track to be approved within the next year. To be available for people to administer this in a very specific context. And psilocybin is starting phase 3 clinical trials. So hopefully we'll see that in the next 3 or 5 years. The FDA is extremely slow in getting things pushed through the pipeline. And the DEA is even slower to reschedule, because this is what is needed for the DEA to say that these drugs are no longer Schedule 1 and therefore can be taken off and can be considered therapies in medicine. And if you want to kind of look at this, there's on my lab website, nielsonlab.umn.edu. I kind of break down each of these. There'll be a link, and there'll be the original references of all the scientific literature that supports these claims. And just to know, because I'm not going into each of these studies in detail, because I want to focus on kind of what's going on with spinal cord injury and some of the data we've generated from that so far. Almost all of the successful therapeutic outcomes from a lot of these studies consistently correlate with the quality of the psychedelic experience. So whether somebody had a mystical experience or some kind of catharsis, where they were able to unpack and process and kind of release something that they've been struggling with, and that very consistently tracks with improved therapeutic outcomes across all of these different domains. So it's really interesting to think about what that means. So these things, while, we know that they are relatively safe, since they've been used for thousands of years in that context, and even things like LSD and MDMA have been used safely recreationally. So it's not just in the indigenous context or the clinical context, but there are some risks and kind of contraindications that a lot of clinical trials will actively exclude people from participation in some of these trials, based on what was learned back in the 50s and 60s, specifically around people that have, that are on the psychosis spectrum or have bipolar disorder, borderline personality disorder. There's quite a lot of cardiovascular problems that can be exacerbated on some of these. So people that have, unstable cardiovascular function or, uncontrolled hypertension will often be excluded. And there's also an element of vulnerability, and there has been some harm and assaults and exploitation that have happened not only in the underground, but also in the clinical spaces as well. So this really needs to be managed, because when people are in these altered states of consciousness, they tend to somewhat fetishize the people that are helping facilitate their healing. And it's really important that the people facilitating and holding space for these people are very aware of that and really keep themselves in check. And it's another reason why usually in kind of the therapeutic model in a clinical setting, there's usually 2 sitters, not only to kind of give each other a break, because these can sometimes be 6 or 8 hour long treatment sessions, but also to kind of hold each other accountable and make sure that no one's doing anything inappropriate with the participant while they're in an altered state. And there isn't actually any empirical evidence in the literature about what some of these risks are for spinal cord injury, which we're trying to address with some of the work we're doing. So in terms of some of the classic psychedelics, there's kind of broken down into these different classes. There's the classical psychedelics like the indolamines, which include LSD and iboga, different tryptamines like dimethyltryptamine and psilocybin, phenolaclamines like mescaline and DOI. DOI is actually used a lot in animal research, entactogenic phenolaclamines like MDMA, and dissociative anesthetics like PCP and ketamine and salvia. And so a lot of these kind of quote unquote serotonergic psychedelics, they actually mimic chemically our own serotonin. And so these include like LSD, psilocin, and mescaline. Psilocin is actually kind of the active form of psilocybin. So if you ingest psilocybin, it gets broken down into psilocin, and that's actually what you would be experiencing if you took magic mushrooms or psilocybin. And in terms of like what receptors they bind to, so most of them are serotonergic. The phenolaclamines are selective for 5-HT2A and 2C. These include things like mescaline. The tryptamines are kind of non-selective for a broad range of the serotonin receptors. And then the lysergamines like LSD are pretty much hitting almost everything. But the common theme here that seems to be really necessary for the psychedelic experience, the sort of profound altered state of consciousness that people experience, is the activation of this 5-HT2A receptor, which these psychedelics seem to be unique for. Like it will bind serotonin, but very weakly. I think serotonin prefers 1A. So it's kind of interesting to think like, what is the purpose of this receptor that's uniquely bound to by these like very potent psychedelics? These exogenous psychedelics. We do have an endogenous psychedelic. Dimethyltryptamine is actually produced in your brain, and it's released at the time of death. This has been confirmed in both animal and human postmortem tissue, that if you induce cardiac arrest, you see a massive release of dimethyltryptamine in the brain. So the 5-HT2A receptor is distributed pretty widely throughout the central nervous system. We see it a lot, mostly in the cortex of the brain. And so this is a PET scan that was done in a 21-year-old versus a 68-year-old. And you can see kind of the areas of high activity here is where a lot of these 5-HT2A receptors are. And you can see as people age, those diminish. And so it's thought that this is involved in plasticity, environmental sensitivity, and brain development. It's able to help promote learning and cognitive flexibility and neuroplasticity. And it's believed that it's also activated through extreme stressors. There are people that will induce altered states of consciousness as a spiritual practice. These are known as aesthetics, but they're like, they'll still pierce themselves or starve themselves to kind of get into these altered states. For time's sake, because I think we're getting close to time, I'm not going to go into this, but there's a lot of work that's being done to really figure out what's being targeted in the brain with psychedelics. And if you're interested in reading some of this literature, I suggest I'll show a slide at the end with some of the references, but there's some other studies that have been doing PET scans to show the kind of relationship between the occupancy of psilocybin in this example to the 5-HT2A receptors in the brain, and that there seems to be, even though there's kind of this like very stark increase in the intensity of the experience, the more receptors are occupied. At some point, there's sort of like a saturation of how much receptor occupancy can be done, where like I don't think you can overdose on psilocybin, for example, because at some point the receptors are saturated and you're not going to get any more activation. And we're also learning from some work also coming out of Johns Hopkins from animal models that psychedelics like MDMA, psilocybin, ketamine, LSD are able to open the critical period of development, which has kind of been thought of as a theory for a while, that, people experience this childlike sense of wonder, and there's this massive induction of neuroplasticity with the brain's ability to change. And that really, what these substances are, the way that they're able to do that is by modifying the extracellular matrix and really reverting the brain into this kind of like critical period of development where there's so much plasticity happening and so many things can be kind of modified and tweaked. And they also found that the duration of this critical period being open, so potentially the amount of time you have to work and kind of tweak these circuits, is actually directly related to the duration of that altered state of consciousness or the drug effect. So like ketamine doesn't last very long, so then that critical period is only open for 48 hours, whereas psilocybin, where that lasts 3 to 6 hours, those effects might last for 2 weeks, whereas ibogaine, which is not really a serotonergic psychedelic, but it is something that is a profoundly intense medicine that's used in Western Africa in an indigenous context. It's like a 3-day experience, and then those effects can last for up to 4 weeks. And this is just kind of confirming in humans that we do kind of see these long subjective effects. This is a study coming out of Switzerland that did kind of a within subjects crossover design where every participant received all these different drugs at different intervals with a washout period to show just how long these drugs last in humans. And also from animal models, we're starting to understand that psychedelics can promote structural and functional neuroplasticity by being able to increase the amount of dendritic spines, which are sort of one of the kind of hallmark facilitators of synaptic plasticity in the brain. And so this is really interesting that, that these can very rapidly, after a single dose, induce this rapid spinogenesis and synaptogenesis in animal models. So this was shown with LSD, DMT, and DOI, as well as a follow-up study looking at psilocybin that showed the same effect. And they actually showed that it correlated with decreases in stress-related behaviors, as well as showing that there was excitatory neurotransmission happening in these new spines that were forming. So what about what's happening with spinal cord injury? So the 5-HT2A receptor is abundant within the CNS, most notably in brain regions implicated in mental health disorders, cognitive processing, and on interneurons and motor neurons of the spinal cord, facilitating sensory motor function. And this receptor also plays an important role in the regulation of skeletal muscle tone via its action at neuromuscular junctions. And in the context of spasticity, studies have shown that just serotonergic agonists, specifically the T2 family, increase motor neuron excitability, leading to spasticity. And then other studies have specified that it's mostly 2B and 2C subtypes that are increasing spinal motor neuronal excitability. And we do know that serotonergic fiber loss after spinal cord injury disrupts inhibitory signals and contributes to chronic pain, spasticity, and autonomic dysreflexia. And so if you look at all of the clinical trials that are happening with psychedelics, they actively exclude people with major physical disabilities for a variety of reasons. And so this paper came out last year really trying to change this, and kind of a call to action that these psychedelic clinical trials really need to be thinking about how they can be more inclusive of people with physical disabilities, because if this community wants to use psychedelic therapy, we really need to understand how exactly people are responding and how to best support people and what are the risks and side effects involved. And in terms of kind of managing mental health in people with spinal cord injury, there is quite a high prevalence of things like substance use disorders, depression, PTSD. And so these are some clinical practice guidelines put out by Asia in 2021. basically trying to break down whether they felt there was any evidence. This is kind of what kind of clinical practice guidelines are based on, whether it's like level 1 through level 5 evidence, level 1 being like, this absolutely has to be done because the clinical trials show that this is the best method. And the only condition where there is this level 1 evidence is for treating major depression in people with spinal cord injury, whereas everyone else, all the other conditions like anxiety or PTSD or substance use or even suicidality all had level 4 type evidence. So it seems that there's more of a push in terms of what clinical trials have been done to really try to tackle depression in people living with spinal cord injury, which is encouraging because if that's the case, then psilocybin might be useful, given that it's entering into a phase 3 clinical trial to treat major depressive disorder and treatment-resistant depression. But the way that those clinical trials are structured, they will not be including people with spinal cord injury, as I understand it. So fast forward to last month. So this is sort of hot off the press. Myself and some others, this is kind of an international collaboration, really trying to put something out in the literature to describe what's happening in people with spinal cord injury, based on some feedback that really only exists in like drug discussion forums like Reddit and the Shroomery, where people with various types of spinal cord injury talk about these very consistent experiences they have on different types of psychedelics, which includes muscle spasms, spasticity. Some people have overheating or extreme thirstiness and dehydration. Some people report pain. And so the muscle spasms is really the most consistent reaction that people report. And some people report it to be very adverse, and some people think it's not that bad. And we don't really have a clear understanding on whether this is level dependent or injury severity dependent, if it's drug or dose dependent. There's just not a whole lot of information out there to really make an informed decision about what's going on. So David McMillan from the Miami project last year started this PsychSpasm survey, which has been completed, where they tried to get kind of an anonymous online survey perspective of people with living with spinal cord injury that have tried various sort of classical serotonergic psychedelics and what their responses were, and looking at the Penn spasm frequency scale in roughly 28 people. Showing that there is this sort of transient increase in spasm frequency and severity that does seem to return kind of to baseline. So there's this significant increase from before they took the drug to while they were on the drug, and then a significant decrease after they've been off the drug, but there was no significant difference before and after. So there's nothing that's like sustaining past this initial experience. But again, these are sort of like retrospective, subjective reports of people where we can't really ask follow-up questions. So even though this is a very consistent pattern and it kind of tracks well with what we're seeing in kind of the Reddit and the Shroomery forums, there's a lot of unanswered questions here about whether it's, different drugs are having different impacts. We do kind of see more of the cervical injuries having this effect than kind of the lower level injuries. So I really think we need to get more information on this to know exactly what's going on and whether it's going to be more severe in certain populations. We conducted our own survey to really get at this in more detail, looking at that same measure of spasticity, but also looking at some more qualitative subjective reports, as well as looking at pain. And so the study is still active. So if people want to contribute to this, it takes about 20 minutes, depending on how many psychedelic experiences folks have had, and really trying to get people with a spinal cord injury that have tried psychedelics after their injury and reporting on how their body responded and whether they had any physical issues that were really aversive, if there were any mental health benefits that they observed, and whether they felt it was worth the risk to take it. And so this study's still ongoing. We've got about 16 respondents so far with data that we could use with varying levels of injuries of spinal level and completeness. It seems to be highly overrepresented for cervical injuries, though. So we didn't get an after time point for this survey study, and actually everyone that responded to this had only reported using magic mushrooms with various either micro or macro doses. So a micro dose would be sort of like a 10th of what you would think of as a full dose, where it's not really having a clear subjective effect. People don't really notice it, but might experience some kind of effect that is kind of subperceptual, as we would call it. But we do see that if you block it by spinal level, that we do seem to see that more of the intensity and frequency of these muscle spasms that people are having seem to be happening in people with the cervical injuries more so than the other injuries, but we don't have, I think we need more data on this to really understand this. But so far, these trends are kind of suggesting that this might be more prominent and severe in people with higher level injuries. But one of the benefits that we've been seeing from this very consistently from almost everyone that's reported this is these reductions in pain, and people kind of claiming that they felt this like interruption of their pain, and kind of getting their body back for a minute while they were on the experience, even though they were having muscle spasms, that in general, they enjoyed it because the pain was going down. And it's interesting to know, pain is kind of a mystery. And so we do know that psychedelics like psilocybin and LSD are some of the only substances that can effectively treat cluster headaches, which are some of the most severe headaches that exist. They're called suicide headaches because they're just so intense. The pain is so intense and nothing really fixes them except for these psychedelics. And so there's this whole group called cluster busters if you're interested in looking into that. And so if you recall, when I was talking about sort of a lot of the mental health benefits that we're seeing from some of the clinical trials really correlates with whether people had a good quality experience or a mystical experience. And so what the preliminary evidence is showing from our survey, where I administered this mystical experiences questionnaire, which tries to kind of quantify this. And we found that it seems that people with cervical injuries are having a lower quality experience for not really having really intense subjective experiences, potentially because of the muscle spasms that are happening that are so distracting that they're not really able to have this like full-blown cathartic experience, which might impact the ability for it to have benefit on some of the mental health outcomes. And this is compared with some healthy people from a psilocybin study that I'm doing, where I use the same measure and kind of showing that people really do have these really intense, beautiful mystical experiences that are really life-changing. But we're seeing less of that happening, especially in the people with the cervical injuries. And I was noticing in some of the kind of open-ended responses, there's trends that people who know what to expect from previous use have a better experience. And so this is really a crucial part in preparation for psychedelic experiences, is really understanding the risks and letting people understand what they're getting into. And a lot of times just sort of knowing to expect can really alleviate some of the stress and anxiety and fear and panic around some of the adverse symptoms that happen when people are in these really intense altered states of consciousness. But if not done correctly and not prepared adequately, it can be harmful psychologically. And so I just want to close out with kind of some of the subjective reports that people talked about in terms of, how intense it was. And you can just kind of see this theme popping up that those with cervical complete injuries really do have a very intense reaction that seems to be really aversive. And it doesn't matter whether they took a high dose or a low dose. It just seems that even just a little bit can induce this really intense experience in people with cervical complete injuries. Whereas those that have the lower injuries and not really sure whether they're complete or not, and we need more data on this, that they're actually having more beneficial experiences. So I think this is something that we really need to investigate more. We have a grant out to the Nielson Foundation to try to get more money to investigate this prospectively by doing in-person interviews rather than an anonymous survey. So really, we need more research and funding on this topic to promote harm reduction. And while psychedelics may help alleviate suffering from mental health complications, the adverse events unique to SCI may prevent this type of therapeutic potential. Also, there's a lot of media frenzy around psychedelics that I think is becoming a problem in terms of the expectations of what people think psychedelics can do. And so I think we need to really be honest about the actual risks and benefits of psychedelics, especially for spinal cord injury. And I think caution should be taken when considering psychedelics for people with spinal cord injury until they fully understand what's actually happening. If you want to take a screen capture of this, these are the different references cited in this talk. And thank you for your attention.
Really great. Thank you, Dr. Nielson. So I see some questions coming. Keep them coming. But right now, as you are typing into the Q&A box, I'm going to introduce our discussant, who is Devin Colbert. Devin Colbert is a medically retired Garland firefighter, father, husband, amateur researcher, and a quadriplegic. Devin was injured in a motor vehicle accident on December 17, 2012, where he suffered a C5 injury. He went back to work after 2 years of therapy and went on disability after serving 6 years in the Garland Fire Marshal's office. He and his wife started a nonprofit, the Colbert Project, to help firefighters and their families facing financial hardships following an off-duty injury or illness. And he has spent the last 2 years researching psilocybin mushrooms and their potential physical benefits for spinal cord injury patients. Devin, thank you for joining us today.
Hello, thank you. Sorry, I guess I should have updated that. It's probably about 3 years now. So, but yes, I'm gonna do my best to kind of, I guess, explain my experience following the presentation. So I guess it was roughly about 3 years ago. I started, or I tried mushrooms for the first time. I've been reading and just hearing a lot about them, and I wanted to see if they could help with just some PTSD and some other past things that I've dealt with. And so ended up trying accidentally 7 grams. And so during that, before the actual psychedelic effects started, the spasms kicked in, and that kind of set me off of trying to figure out, you know, why the spasms happened. So that led me down the rabbit hole of learning about serotonin agonists and everything like that, and then really just seeing kind of the interaction with the 5-HT system. I really don't know. And going back to the paper that was just released, it is true that it can induce the increase in body temperature, blood pressure, and everything like that. But with a spinal cord injury, those are some of the things that I deal with on a normal basis of being hypotensive and lower body temperature. So it actually helps me bring my blood pressure back up to kind of a normal state to where I'm not feeling lethargic or anything like that. Now you do have to be careful in environmental settings. If it is too warm outside, you can overheat pretty quickly like that. The pain relief aspect, that I think is in turn due to the activation of the 5-HT 2A receptor, that in correlation with the KCC2 potassium channel, ion channel. I think that helps bring it back up to kind of that normal basis, and then that's where it keeps that pain relief. I've been microdosing now about 100 milligrams a day for the past 3 years, and I've noticed just a tremendous improvement in quality of life. Pain relief aspect is, I know exactly it's going to kick in about 30 minutes after ingestion. Spasms, they're not too bad. They can be mitigated just by postural changes and everything like that. But I feel that that's a positive just because it helps keep circulation in the muscles, helps keep my muscles, um, you know, from atrophying away. What else? I've just seen extreme positives with it now. And again, also too, with the microdose level, I think it can help with the depression and everything just from, um, just that little bit of a extra boost, I guess. I don't know. I'm really open to questions, and I'm happy to kind of answer any questions that y'all might have from me being in the experience and everything like that. I guess I don't know.
Well, Devin, we do have a question from Dawn. She says,
Okay.
did you have previous experience with psychedelics? Have you tried other medications,
No,
treatments like ketamine? No.
no, I had no working in the fire department. I had uh, nothing to do with cannabis, psychedelics, anything like that. I just kind of researched it from watching podcasts of people talking about the neuroplasticity effects of mushrooms and the possibility of them. And so my thought was, is if the brain can be kind of rewired, or that, then why can't the spinal cord? And so I was looking at it more of kind of less a way of looking for a therapeutic aid in just trying to help me see what kind of function I might be able to get back. And so the first time I took them, though, was with the 7 grams. I was going in for it with the psychedelic experience, but that was more or less trying to deal with the anxiety and PTSD that surrounded my accident and me trying to drive and everything.
Great. Any other questions for Devin or Dr. Nielson? I see that Dr. Nielson. Oh, go ahead, Devin. Sorry.
I was just going to say, I do believe that there is it definitely needs to be investigated a lot more for its therapeutic benefits. But I guess it's just more or less a question of what is the outcome you're trying to look. Are you trying to get the big psychedelic experience for the depression, or do you think that it can be used in a microdose setting to where you can address the depression just over kind of a little bit longer period of time? Because I've noticed too that it does allow you to kind of, instead of being in that kind of depression, because I've dealt with depression and everything like that from an early age on, 17 years old, and I'm turning 40 tomorrow. So this is one of the one things that's actually helped me over the past years and everything else like that.
Right. Any other question, or let's see, maybe this is for Dr. Nielsen. Have members of your clinical, oh, no, this is for you, Devin.
Okay.
Members of your clinical care team been supportive of your journey? Great question.
Oh, yes. 100%. I guess really it's just my wife who's kind of supported me through this, but she's seen, uh, just how much it's helped me, especially along with taking the pain away. Pain relief is usually about, I mean, I can notice it, like I said, it kicks in about 30 minutes after ingestion, and then it usually lasts 8, 10, 12 hours throughout the day. And then the pain after the fact is very, very minimal compared to whenever I don't take it.
Let's see. Have you noticed positive physical changes over the course of the last 3 years that you would attribute to microdosing?
Yes, 100%. I've seen, especially during my workouts, I've seen increased strength in my triceps, which I didn't really have triceps to begin with, but now I can move weight against gravity. And the muscles that I did have, like my shoulders and my chest, I've been able to increase my muscular in my chest area, and then also my shoulders and everything. Uh, I hate plugging it, but if you go to my Instagram, you can see the progression from my workouts from when I actually started putting them on there till now, and you can kind of see that was kind of like my video documentation of this is what I started and this is how I started doing it, and then here I am now.
Well, if you're interested in sharing your social media handles, I think there's some people in the chat that might be really interested in reaching out, perhaps. I think we have time for maybe one more question. Maybe this will be for Dr. Nielsen. How can medical professionals that are interested in this research become more involved?
Yeah, that's a good question. So there's a couple training programs right now. The Multidisciplinary Association for Psychedelic Studies has a therapist training program, because once MDMA becomes FDA approved, it's not just going to be like you're prescribed MDMA and you go home and take it. It has to be done in kind of a clinical setting with therapists that are certified to actually be MDMA therapists. So there's not enough of those therapists now. So if you go to the MAPS website, maps.org, or MAPS Public Benefit Corporation, there's a link to a training program there. There's also the California Institute for Integral Studies. They do a certificate in psychedelic therapy and research. There's a program through Fluence, which is another psychedelic training organization that's specifically trying to train therapists in states where they've legalized it for therapeutic uses, like in Colorado and in Oregon, to help people become psilocybin-assisted psychotherapists. We might see something like that coming online in Minnesota once the Psychedelic Medicine Task Force sort of approves this in the legislature, hopefully getting LSD, MDMA, and psilocybin legalized for medicinal uses. So there's a lot of training programs out there. Those are some of the ones I would recommend. There's a bunch of them popping up that I don't know all really know what they're doing. The space is becoming a little intense, and there's a lot of people trying to make money off of this. So those are the ones I would recommend at this time. But hopefully something like the American Medical Association or the American Psychological Association will have something more formal in the years to come once these things become more integrated into Western medicine.
Wonderful. Well, I think being cognizant of the time here, if you wouldn't mind sharing that last slide, Jessica, I will wrap up, but you might want to address a couple more questions in the Q&A in the meantime.
Yeah.
Awesome. So thank you everyone for attending today's grand rounds. We apologize that not all questions were answered, lots of good questions, but do feel free to reach out to the presenter directly if you would like some follow-up regarding your question. And the recording for this webinar will be posted soon on the SCIMS website with a link to our YouTube channel, which is where all these are archived. So as a reminder, see the chat information on how to obtain CME credit for attending today's webinar. At the end of the webinar, there'll be a brief 3-question survey that pops up. We would really appreciate your feedback. We also hope you can join us for our next grand rounds on Thursday, October 5th at noon Central, where Sophia Bowens and Ricky Lopez will present integrative health approaches for spinal cord injury, acupuncture, and adaptive exercise. Thank you, everyone, and have a wonderful rest of your day.